Okay, good evening all and welcome. I Sandeep Bagla from NATCO team. You are listening to another special episode of Respire, one voice at a time. Respire, a podcast series navigating the journey of lung health and its awareness. So, and you know, all lung cancer is a common and very related deaths in India. There is a lot of misconceptions as well as myths to understand this cancer. So, to clear all the doubts and to clarify us, we have with us Dr. Amit Ghanekar, Director from Indian Cancer Treatment Center, a renowned medical oncologist, works in chain of chemo daycare hospitals and also Fortis Hospital Kalyan. And over to you, sir. Thanks for your valuable time and welcome, doctor, to this platform.
Yeah, thank you for this lucid introduction. And without wasting time, I assume we can go over to the question and answer session. Everything about lung cancer.
So, anyways, today the general audience is the audience are so listening. So, coming to the lung cancer awareness, sir. So, to understand the burden and the incidence. So, why is lung cancer is becoming more common, sir?
So, lung cancer, I would rate it as 5th or 6th most common cancer and something that deserves treatment. Incidence seems to be going up because there was an era 20 years back where we used to see more of smokers coming with squamous cell carcinoma of the lung. In today's are the adenocarcinoma variety, which has nothing to do with smoking. Classically supposed to be a cancer of the non-smokers. So in my understanding, it seems to be on the rise because of pollution. No wonder we are seeing people in 30s and 40s of their age coming to us with lung symptoms, diagnosed as lung cancer, biopsy coming up as adenocarcinoma.
So it's quite common in
the number of patients who are actually non-smokers who come with adenocarcinoma type of lung cancer is on the rise. And my analysis for this is definitely the pollution component. What I struggle to understand when I see a young patient, 42 years of age from Kalyan, who has come to me with stage 4 lung cancer, there are many hundreds of 42 years, and why are not they affected by means that is where your vulnerability, or in my words, your naseeb is, but then the background is the added pollution, for sure.
Okay. So anyway, sir, my next question was that only. What are the other major risk factors other than any pollution is also comes under this?
Yeah, pollution definitely, and then classically what we always say to avoid is the smoking component in all forms, then chemical exposures, then exposures in factories where asbestos and those carcinogens that are inhaled, they are known to be the classical risk factors, but it typically are known to cause the squamous type of lung cancers.
Okay, sir. And when coming to the detection thing, is it so very important, sir, for early detection of lung cancer?
As compared to a cancer like a breast or a colon, lung cancer, very sadly, most of them come to us in slightly advanced stages. And that is because the initial presentation is very vague. It could be just unexplained cough, it could be some vague pain, it could be some vague backache, it could be some vague fatigue, some appetite loss. Generally, that is attributed to other common etiologies and sort of neglected by the patient or by the level 1 of doctor. So many a times these patients do come to us in stage 3 and stage 4. COVID, during the time of COVID and the post-COVID, we are seeing stage 1 and stage 2 lung cancers as well, but them catching most of the patients in a very early stage, which is very, very curable, it's extremely difficult because of low suspicion then.
Okay, sir. And what are the common symptoms should not be ignored by the patient?
Symptoms like somebody has unexplained cough or persistent cough going for more than a couple of weeks, unexplained fatigue, having some systemic symptoms like low grade fever, not eating well. Sometimes the cough has sputum which is tinged with blood, or sometimes you have a facial swelling. These are symptoms which could indicate that a lung cancerous growth has started. It is causing local symptoms or it is causing some local pressure. So that is where we want the primary level of doctor, the family physician, who is generally the first line of contact for the patient, to be strongly suspicious and actively investigate.
Available are accessible for the patients, diagnostic methods and
Yeah,
tools.
I mean, I am based in Kalyan, which is I could label as a tier 2 city. Even in a place like Kalyan and Dombivli, or even beyond of this place, you have simple X-rays and CT scans easily available. So strong suspicion is where it starts, and then we would straight away ask for a simple chest X-ray, which is very easily available, very cost effective, and it may give you a good hint of how strong your suspicion is. And then you probably can go on to further tests like a CT scan, which can catch most of the cancers. And then obviously whom the patient is referred to will go for further testing like a biopsy, PET scan, and so on.
So this low dose CT scan is really accessible. That is what you're saying, sir. In tier 2
Yeah, I
cities
mean,
like or tier 2 districts like Kalyan, because
yes, CT scan is not really so difficult. It is one of the over-the-counter investigations today. So I would rather tell my family physicians, the moment you have something suspicious in the lines of a potential lung cancer, check for the patient notes, any signs of decreased air entry, any fluid collection in the chest. Anything is on those lines, straight away go for a simple chest X-ray, and if possible, straight away a CT scan chest. So if these reports come positive or they still remain suspicious, then they should be further investigated in a methodical way so that you actually end up diagnosing a cancer.
so when we talked about, we already talked about diagnosis and understanding the incidence and symptoms also. But when you see on the treatment and the evolution on innovation of the treatment, you talked about last 20 years you are seeing. So what kind of treatment evolution has happened in lung cancer, sir?
I can't hear you. Dear, you are not audible.
Okay. I am saying what kind of evolution, treatment evolution you saw is there in lung cancer? Hello? So can you hear me? So I was talking about treatment and innovation, sir. What kind of innovation you see in last 20 years of your career in treating
Yes,
lung
sorry,
cancer?
I
Treatment
just
evolution.
lost your voice. I am only able to hear you right now. Could you please repeat the question?
Treatment evolution, sir. In last 20 years or last decade, if you see, what kind of treatment evolution happened in lung cancer?
Yeah, surgery has been the gold standard for lung cancer or any cancer for that matter. But as I said, 80% plus of these patients come to us in an inoperable stage. That is, we will always want to treat them with a palliative intent so as to really increase their life meaningfully. The options have been conventional chemotherapies. In the last decade, we have seen the wonder of immunotherapy, and last 15 years, I would say, has been the era of chemotherapy added on with targeted therapies, the oral TKIs, which have been a great game changer. They have led to a paradigm shift, especially in the adenocarcinoma types. And what type of lung cancer, apart from just lung cancer and the stage, and we also desperately actively try to hunt for mutations so as to have a target which is like the Achilles heel or the weak link of the cancer. The patient's life is made much more peaceful by simple tablets.
Okay. So when you talked about this targeted therapy, what kind of role targeted therapy has? for to
So
understand for our
as I
general
always
public?
quote in my OPDs for the patient and the caregiver to simply understand it will have results, but it will have
Okay.
consequences because it's a bit blind in its attack. So target therapy is a smart weapon. So, for example, an adenocarcinoma lung patient, if this patient has a mutation, I use a Timple tablet which targets this mutation. And by doing that, the chemotherapy very nominal toxicity, and because these being tablets, you can put them on simple oral pills and follow up them on OPD basis.
Okay. And immunotherapy, sir,
Yeah, so just to
the same thing.
make up for the targeted therapy answer, it all began with one mutation in 2003. The tablet was imported then. Today we have it made in India. Even your NATCO gives it at a very nominal price. Each of which has a tablet, and in most of them today we have advanced from the first generation. Like you have erlotinib and gefetinib for EGFR mutations, which came with limited benefits, some toxicity concerns, and some limitations, like not being able to be effective in the brain and so on. So then came the second generation. Today we have the third generation, and this evolution has happened in most of the targeted drugs. So every patient type who has got a mutation, it could be somebody who is 62 or somebody who is 82, not so fit, or some coffin. All these patient types can be very peacefully catered. Obviously, you need to hunt the mutation and you need to wisely choose your target. So that's a very big spectrum covered, big spectrum of patient types. About
Okay, sir.
immunotherapy, I would rather label this as a smart weapon. What immunotherapy does, in the simplest words, it removes the disguise of the cancer cells so that your immune system, which was so far unable to figure out कि अपना cell कौन सा है, दूसरा cell कौन सा है, it makes them identified very, very precisely. And by targeting these cancer cells, the immune system triggers an attack and kills that. So this is a very smart technique of using your own tools, your own armamentary against the bad cell. What they negotiate is the peaceful identification of these cells. And no wonder immunotherapy is known to have responses in the rightly start being effective. So eventually they have superseded chemotherapy because chemotherapy comes with a Lakshman Resha where you have to stop. Whereas immunotherapy, there is no per se worry of stopping because of toxicity. So it just keeps on going. We have seen that happening in lung, we have seen that happening in other cancers like melanoma, we have seen that happening in kidneys and so on and so forth. But yes, lung cancer was one of the uh, cancer types because most of them in advanced stages, we could barely see them going over a year. This is I'm talking about the 2010s, 2015 ka era. And then came in immunotherapy. And now we have people who, in spite of being stage 4 at diagnosis, whom we are able to properly sequence our medicines, we are actually able to make them live years with good quality of life with a small IV dose of immunotherapy.
Okay, sir. Whatever you have described, two things, sir. One is the lot of treatment options are available. Evolution has been done with the lung cancer treatment. And second thing, sir, when these treatments are available, how does you personalize the treatment plan, sir, for a patient? So,
So once we have a suspicion of a lung cancer, what we ask for is the biopsy, so that we have a proof that it's actually a cancer originating from the lungs. In any gray situations, we would go for immunohistochemistry markers, IHC panels. We'll probably also go for PET CT scan so as to very clearly delineate the stage, so as to identify potential sites for complications, like having a venous vessel that is blocked, or having a potential weight-bearing bone that is showing the disease to avoid a fracture. So once that is outlined, once we know the stage, once we know the type of the cancer, we would go for the conventional mutations, especially in the adenocarcinoma type, or we would go for an NGS panel. At the same time, on this block, we would also try to identify the markers, something like a PDL1 or a CPS score, which will help me to handpick my patients who are going to be benefited with immunotherapy the most. So in an advanced stage, what matters for me, apart from diagnosing, knowing the type and the stage, is how smartly I
Yes.
sequence my weapons. So when you want to palliate, control a cancer, what goes on in an oncologist's brain is to sequence your medicines, the oral tablets, the immunotherapies, the chemotherapies, the refined versions, so as to make them live eventually much more longer and also make them live much more better.
Okay. Sir, this and again coming to accessibility and affordability, sir, the patient. So is this treatment, whatever you talked about, immunotherapy, targeted therapy, how often it is affordable to the patient, sir? Patient.
Yeah, immunotherapy, as we all know, it is one of the drug as of now not made in India. So it definitely has some cost barriers, but there are various patient assist programs, and in our centers like case, where our sole motto is to not just start treating somebody, but to ensure that the treatment is completed. We try to offer these patients a lot of apps, which is definitely helped by our pharma industry, the patient assist programs. And what we all are aware of, or what we are strongly contemplating and hoping and expecting, that at least a few immunotherapy molecules are expected to be launched in India. So here, as we have seen in many other targeted drugs in the past, in the last say 10 years, that the cost barrier has just vanished.
Yeah. Okay. And sir, is there any major barriers to assess quality cancer care in India? As per your,
Yeah, so don't really get treated well. It is probably because of late diagnosis. So either suspicion is not raised early, or that suspicion is not respected by the patient early. And then many times it is the cost factor and the toxicity. That is where patients either don't start or they don't stick to the plan. So minimizing the toxicity by smart utilization of your weapons. So chemotherapy is not just one single drug, it's a big armamentary. It is our skill and acumen to use what drug to where, in which particular type. And then the cost factor, we definitely actively try to take care, so that that should not be a reason for somebody to miss his treatment, because in the cancer therapy, what matters is the drug dose or the doctor. Rather, I would pitch in the timing as the most important factor. Once lost, can never be regained.
okay, sir. And anyway, sir, you have an expertise in treating tier 2 cities and tier different parts of Maharashtra and other belt. So, what kind of advice you want to give a patient who is coming from a rural patient who is trying to navigate treatment? What advice you generally give, sir, to those kind of
So
patients?
we would just tell any patient that once a doctor has a suspicion, get investigated and then say all is well. Or in case you have been diagnosed with a cancer, especially something like a lung cancer, always seek advice from an experienced and oncologist, somebody who is qualified, because it is, even though a team can win the cup, it is the decisions by the captain that will matter the most. So that is where our role comes. We are not playing a pivotal role of sequencing the treatment.
Yeah. Okay, sir. And when we talk about the psychosocial impact, the impact of quality of life, other things, the mental health, how does you counsel those set of patients, sir? Because cancer is not about a single word; it
Yeah,
affects the entire family. So the
yes. And
patient
the
already
point,
is in.
yeah. I mean, I would completely agree with your concern that cancer is a fight which the patient does, but the family is involved. There'll be people around him who will be concerned or worried or have their own ideas, and it just doesn't happen. So there is where we keep on repeatedly counseling the patient, talking to the patient and the family about the facts, about the myths, about what to do, about what not to do, about what are the treatment options, about what are their limitations, their toxicities, their concerns, what should we expect in the larger picture, so that we want them to be in the fight. They want them to stay put with a clear mind and a better acceptance of whatever is going to come in their share.
So there will be a role of caregivers also, no, sir? Because from starting of the patient
Yeah.
for
So
mental support.
we try to have a good counseling at day one. We keep on talking to them repeatedly. We keep on updating them about any good or any bad surprise that has come up. It can be nutrition, it can be genetic counseling, it can be other thoughts. We will make a point as you go ahead to very clearly talk to them about the myths, about the facts, because this is from the nearby neighbors and everybody around. These things keep on nagging the patient, and they unnecessarily live in a lot of anxiety, which I make a point to relieve that by putting across the facts repeatedly.
So you just now you were saying, sir, advisors, and when we talk about misconceptions, also myths in the society, people will tell that this is happened, this is going to happen. So what kind of misconception you generally heard from your patients? One misconception.
The moment
Generally,
we start talking to a patient about chemotherapy as the opening treatment or the first line of treatment for a cancer, something like a lung cancer, there are worries that it would be very painful. It could cause lot of burning. The side effects will be so horrible that pinch of sugar, because that will magnify the disease. There'll be worries that this could spread from the grandfather to the grandkids. So people are actually keeping the patient in isolation. They are a bit afraid to touch the patient, or use their napkin, or use their glass of water. So we try to put across these things, and this is not contagious. This is not something that you should be worried to shake your hands. Diet matters. So have a clean, fresh, hygienic, homemade stuff. Sugar definitely doesn't instigate a cancer. So if you're having a cup of tea in the morning, don't stop that. But then obviously stay away from unnecessary chocolates as well.
okay.
And then there are many things beyond that. If somebody has a cancer, there is a fear that everybody in the family generation next is now going to have it.
Yeah.
So these are things we keep on repeatedly telling them, because we want their energies to be channelized against the physical issues of chemotherapy, and not this mental agony which comes from some silly advices all around.
Yeah, sir. One last question from general public. Sir, as your experience keeping in your mind, and as working as a director for Indian Cancer Treatment Center, handling or managing entire chain of chemotherapy centers, what is your best advice for our audiences
Yeah,
to
so
fight against
once
lung cancer?
somebody is diagnosed with a cancer, there is no running and fooling around. भागने की कोशिश जो करता है वो आगे जाके बुरा फंसता है. So
Yes.
before taking a decision on your own level, good to see a qualified oncologist. Try to understand the severity of the situation, the treatment options, and the various practical aspects like the cause, the toxicity, what should you look for from the treatment. And once only you get to understand the entire scenario, the larger picture, then take a wise call. So any oncologist who is qualified is going to see the patient. The moment we see no chance in treating them, we feel bad, but we very plainly tell them to go for palliative care only and not to choose
Yes.
active treatment. But that's a story for probably 5% of the patients who come in our OPD. Otherwise, in most of them, we have many good things to offer. And today, in the era of non-chemo oncotherapies, technically that is an oral tablet, or it could be immunotherapy or a targeted drug, or the ADCs, we have lot many things to offer who can definitely achieve a meaningful addition to years in somebody's life. And this I am talking about stage 4 cancers who are otherwise sort of advised कि ये तो stage 4 हो चुका है, nothing much to offer. So before an oncologist agrees to that comment, don't give up.
Okay. Thank you, sir. Once again, thanks from our platform. And this is a joint initiative by Voice of Healthcare and NATCO team. And thanks once again, sir, to for throwing some light and also clarifying some misconceptions and also some explaining vital aspects of lung cancer to our audience. Thank you very much, sir.
Fine. My pleasure.
Thank you very much.
My pleasure.
Thank
Thank
you.
you. Thank you.
Thank you, sir.